Kia ora everyone, and welcome back to our next session on optimising data for health, which has been some collaborative work between ACC and MIT Critical Data. And I'd like to welcome up our chair for this session, Dr. Sean Sterling. Sean is an anaesthetist and intensive care physician in Wellington and has practiced for the past 12 years with 6 years as a medical director at Capital and Coast. He's also, over the past year, been a visiting research scientist with MIT Critical Data, Leo and the team, and his research interests include secondary analysis of electronic health records and data science in health services research. Thank you, Sean.
Thanks, Matt. Hello, everybody. And I have the pleasure in a couple of minutes of also introducing the next three speakers who will talk to the project that we've been working on. But first I thought I'd start with a quick story and put some context around this. So I live in the Wairarapa and I practice in Wellington, and I've been there for years, 16 years. And last year I moved to Boston, and a couple of the first people that I met getting off the plane in Boston were actually two Kiwis from Wellington. So I'd gone all the way around the world to meet somebody who's just 100 yards down the road. But it was Scott Pickering and Dame Paula Rebstock from ACC, the two people I met. And they were on a trip around the US, meeting and forming collaboration with people, one of whom was MIT, as part of their transformative journey that they're on in terms of understanding how they increase the value for each and every one of their customers, particularly in our respect using data. I've been struck, that meeting led to 8 months of collaborative work between MIT and ACC. It led to ACC becoming the major sponsor for this event, and it led to ACC inviting MIT team and a team from the Ministry of Health to spend a day earlier this week working with ACC from the executive down. I had a fantastic day, and this is what this session is all about. It's trying to put this all in context going forward. ACC has obviously a lot of data, but it also has some globally unique data, and I think particularly in terms of its treatment injury stuff, because normally this sort of data is locked away because of its undertones in databases that are hard to access. And here we have it in all of its glory because it's collected essentially without blame. So I'm looking forward to the potential to work with MIT and ACC, particularly with respect to this precious treatment injury data set. Having said all that, what I'd like to do now is bring three of the people that have been fundamental to this week and this project onto the floor so that they can report back on this. I might ask the three speakers to come up and have a seat. So first I'll introduce Nick Kendall, who is the Manager for Treatment Safety at ACC.
Hi.
Nick, yep. Dr. Peter Jansen, who's the Clinical Lead for Treatment Injury at ACC. And Zeeman van der Merwe, who is one of the managers for information strategy. Now, these three will be presenting, but we've been working with a team of more than 20 people for the last 8 months, and some of them are in the room, and some unfortunately couldn't be here today. Okay. I'll let you take over.
Sure. Okay, so thanks very much. The three of us are just going to do a little piece of this each. So I'm just going to run through some material first and then hand over to Pete and then finally to Zeeman. And so I must say how much we've really enjoyed this conference and how delighted we are to see clinicians and data people together in the same room discussing the same problems. So, as everybody alludes to, ACC's got a lot of information, and that's been built up over several decades. And that varies from very straightforward stuff through to very complex stuff. However, major challenge for us is that currently only a proportion of it, and a fairly small proportion, is actually machine readable. And so that does provide some limitation to what we have. So the treatment injury data set is smaller, and it's actually, in a sense, a separate database. It has its own limitations as well, but we have been able to very extensively investigate this, which has led to targeting some prevention issues. And we're now getting ready to start to explore the potential applicability of algorithms here. So our partnership with MIT is not just for treatment injury, but obviously right across the whole range and looking for potential action with regards to that. So just a really quick reminder for you, the ACC scheme basically gets divided into 5 separate accounts. And so, when you're at work, you're earning. If you're not at work, or you're still at school or elderly or whatever, you're on the road, etc. But also when you're in healthcare, and that's the treatment injury side of things. So this is the 2017 data for the calendar year, and you'll see that we get pretty close to 2 million claims per year. So when you look at the way those are distributed, as you can see, less than 0.5% treatment injury cases, but we're going to use that as a little bit of an exemplar for you today. And in order to do that, I'm just going to ask Pete to give you a little bit of background of what a treatment injury is, just so that just a couple of slides here, just to make sure that you're on the same page.
Kia ora koutou. So we have, I'm going to take a sip of water. You all know that ACC covers all New Zealanders for injuries caused by accident, including New Zealanders that are overseas. Forget about that. Let's come back to treatment injury. We used to have medical misadventure prior to 2005, which was a very complex bit of legislation with very defined parameters. And it was changed in 2005 to treatment injury with a more liberal regime and attempting to avoid the blame culture, which is part of medical misadventure, particularly when there was medical error, somebody did something wrong. So we shifted more to the no fault, more towards the no fault, and what it is personal injury caused by treatment. The treatment has to be by a registered health professional, which is what we have up there. It's not any old registered health professional, it's a registered health professional in Section 6 of our Act. Not all the regulated health professions are covered by ACC. I labour these points because ACC exists because of the legislation, so you need to understand the legislation in order to apply the data and think about what data we hold, to apply the legislation and understand our data. There are other exclusions, and I'll come to those over the page. Personal injury is also defined, and the courts have said it's actual bodily damage. So tinnitus is not an injury for treatment injury. Vertigo is not an injury. It has to be actual bodily damage, which is where one of the first exclusions comes to. People have adverse outcomes from the treatment that you deliver to them that are nasty, but they don't amount to physical injury. Thinking about the registered health professional, our focus therefore is on the regulated health workforce, those people listed in Section 6 of our Act, who are regulated for a reason. Treatment can cause harm. You all know that, both the benefits of treatment and the potential harms of treatment. So that's why we're captured by ACC, and that's where our focus will be in trying to prevent harm. Here's what's in and what's out for treatment injury, and it's way different than the rest of ACC, as I said. So because of these exclusions, 40% of treatment injury claims are declined. So understanding the declined will give you a rich set of data as well as the accepted claims. Treatment is a very broad definition. It's basically everything that you do, from going to see your family doctor to ask about symptoms right through to your recovery from your illness, including all the diagnostic investigations and treatments that go on. So therefore, one of the treatments that might cause injury is failure to provide treatment. So if your doctor or nurse or pharmacist could and should have done something different, that may be the cause of your injury. The obvious example is you front up to your family doctor with a big black lump on the side of your body and it's been growing and itching, and he says, don't worry about it. In fact, it was a melanoma and it started to metastasize. That will be a failure. We would accept the claim, and your injury would be progression of your cancer and spread to other parts of your body. So still a little bit of fault in there, a little bit. Similarly, obtaining consent and the application of support systems. I'll run through these without too many examples. Early premature failure of your equipment, a device or a prosthesis, can also be treatment that causes injury, so premature failure, not the wear and tear of your replaced hip or your replaced knee. And then excluded, and there's some really key ones here. The first one is necessary part of treatment. If you have a appendicitis, somebody will need to make an incision to remove that appendix. It might be a small one and we'll stick a laparoscope. It might be a big one and we'll take out the pustular mass inside you. But in any case, we need to make a cut. That's necessary. That's not an injury that we accept. That's excluded, the necessary part. Ordinary consequence of treatment in the circumstances is also excluded. The legislators gave us no more definition than that. It's a very hard part to interpret, but it's a large chunk of declines. The ordinary consequence. An example would be if you needed a midline incision to repair your ruptured aortic aneurysm, your chances of getting an incisional hernia are over 60%, probably because you're a smoker to get your aneurysm in the first place. And that will be excluded. An ordinary consequence of treatment in the circumstances. Not following your doctor's orders also means that if you get injured, you're excluded. That's withholding consent. Resource allocation, we won't go there, and wear and tear, we've talked about it. The last one, desired results not achieved. So if your injury is in fact, you just didn't get the result you wanted, that's not an injury for ACC purposes. The obvious one is like a cosmetic procedure. I want it to be much more beautiful than this, but this is all they could do. Why are we talking about treatment injury? You saw in the previous slide that treatment injuries are 0.41% of all ACC claims. So less than 0.5% of all claims to ACC are treatment injury claims, but these claims are more costly. They take a lot more support to help the patient recover. Particularly if you think about the nature of the type of treatment injuries, things like deep tissue space infections, they don't get better overnight. They take a long time, a lot of support. So the costs have been going up, and you'll see the pattern there from the beginning of treatment injury in 2005. It went up pretty rapidly. There was a levelling off. I'm attributing that to the global financial crisis. All insurance companies see a flattening of claims during periods of economic uncertainty, and then it took off again, and it's going up at a rate of knots. So people like Professor Gorman, who are on the board, got agitated about that. Is that a fair comment, Des? Yes, there you go. Because not just the costs we pay every year, which is $142 million in one calendar year, but the incurred costs, which is taking account of all the future costs of those injuries. Because remember, if you've got a claim with us that accepted, you're with us until you recover. So there might be long-term costs going into the future. And that last number is the really important number. So thinking about all the people that have ever had a treatment injury or medical misadventure claim accepted by ACC, we are required by law to have available money in the bank to take care of your needs until you're completely recovered or no longer with us. All of your costs, home help, income support, vehicle modifications, all of that stuff. We have to account what is that number and have it in the bank. For treatment injuries, which is, remember, 0.41% of all claims, it's 5.7 billion. It's a big chunk of money, and that's why we need to do something to prevent treatment injuries. Back to Nick.
So a quick way to think about the outstanding claims liabilities if the government decided to shut down ACC tomorrow, this is what would still have to be paid out. So the response to this has been, as Pete was saying, to have an increased focus on prevention. And as most of you will be aware, ACC, since we began in 1974, has not been actively involved in patient safety. So, sorry, just going back there, this is the cover of our publication of treatment injury data. So the first year we put this out for all DHBs. Last year we included the private surgical hospitals, and this year we'll be including general practice settings as well. So we'll be covering essentially close to 90% of the treatment injuries as part of our publication. So the remainder that's left is things like aged residential care and some other community areas that we will get to. So in our very first slice at looking at this data, not just looking at cost, but also looking at numbers and the impact. Now remember, cost is a proxy of the impact on individuals. In other words, the more that it costs us means that that person and their family has also been very much affected. So I think it's very important to focus on that aspect. So the particular areas that we have set up prevention initiatives, so one has been running here with a partnership with University of Auckland, which is surgical simulation training to reduce perioperative harm. And this varies from the obvious things like operating on the wrong patient or using the wrong surgery or the wrong side, replacing the wrong hip, etc. Fortunately, it doesn't happen too often, but we do get cases every year, etc. We also have a neonatal encephalopathy prevention program. For those of you who are not familiar with that, this is a hypoxic birth injury. Now, again, these are the most expensive claims we have. We take in, on average, just over 12 a year, and they will cost us up to $60 to $70 million that we have to reserve for that. And again, that's an indication of the severity of it. And remember, the parents of these children very often, they don't work again, etc. So the impact is a great deal wider. There's a very large number of pressure injuries, every part of every health system in the Western world. The scientific evidence from the international guideline group is that 95% of them are preventable. However, we still estimate in New Zealand that there are 50,000 of them a year. We have a big focus on our serious injured group, people with spinal cord injuries and moderate to severe brain injuries. Over 40% of them over a 2 to 3 year period have stage 3 or stage 4 pressure injuries, which are massive impacts. Some of those might require hospitalisations up to 6, 7 or 8 months. We're also interested in medication harm, and I'm going to give you one specific example shortly, and obviously healthcare acquired infections. They're in fact our most frequent claim, and in fact the vast majority of those are infections that occur either post-surgically or post some other invasive procedure. And again, they're one of the most common things that come up in general practice settings from doing minor plastic procedures. So we have a rich source of data, and part of that is because these are complex decisions, we need to draw in a lot more information. So instead of the usual 4 months maximum to make a cover decision, we have 9 months, and that could be extended in this area. But as I said, we do have this major challenge that a lot of it is not machine readable. What actually has happened is that these are PDFs that are stored as images. So one of the things that we have done is created a text mining tool which actually converts that to machine readable stuff, so that then we can actually run algorithms through it. And that way we can uncover things like what was not known before was the high rate of pressure injuries, for example, in our spinal cord injured group. And currently we've uncovered a lot of sepsis as well, for example. So what all these do is help us with some of our more advanced analysis. And what we're hoping to do here is not just to focus on prevention, but also the decision-making processes and the case management to enhance recovery or provide long-term support as required. So example of 3 problem statements that we've discussed with MIT in our workshop were to look at are there some factors that predict recovery. Now, in the insurance world, recovery usually means the duration of the claim, and I guess to some extent that's always true for New Zealand as well. So that's essentially our dependent variable. And obviously there's a wide range of independent variables that we can look at there with regards to what might be predicting the duration of that. We're also interested in horizon scanning of some variety, particularly about emerging treatment safety issues and the possible development of tackling that a little bit more at an earlier stage. I think most of you will have seen in the New Zealand media over the last few years a lot of items about surgical mesh, and certainly that is something that came to ACC without us noticing that it had happened. So we had several hundred cases that came to us before anybody actually realised that something was happening. So that won't happen again, but we're also interested in actually having a far more intelligent way of doing that, using machine learning. And also there are sometimes new devices that come on the market. Some, again, you will have seen in the news media, things like eSure, which is a contraceptive device, and things like metal-on-metal hips. They all have provided major safety problems and recalls in the world, etc. We also have a legislative requirement to report risk of harm to the public, which means that we then report that as a prevention strategy, and so we're keen to detect trends that might occur there, and that's one of the things that we're looking to do in combination with other agencies like the Health and Disability Commissioner, MedSafe, and the Ministry of Health. So obviously, I mean, the method for the way that we're going about doing this is a very straightforward approach of working out a question, some analytics, and some action. I'd just like to go through this a little bit because some of the focus on the problems, obviously how you prioritise these, there's a bit of subjectivity to this because you can go for volume, value, and so forth, or a mixture of both from that point of view. But by itself, that doesn't tell you everything. There's also the issue of, can you actually do anything about it? Is it actionable? What is the risk to patients? And in fact, is there something that is actually preventable? So for that, we've needed to stratify the data. Now, to do that, what we're coming up against as a major problem is legacy coding systems. So we've had to put in a lot of effort into mapping to more accurate ways of doing that. So we know there's a lot of data sources, and we're extremely keen to do a lot more linkage. We have our claims data. There's obviously a lot of health data. There's the Ministry of Health, Health Quality Safety Commission, HTC, MedSafe, everybody holds data. And as you heard this morning, the IDI is another strategy to try and link all of this. And that being done in an anonymised way, it makes no impact whatsoever on claim decisions, but it can make an impact on prevention. And obviously the only people who can make treatment safer are the clinicians and the organisations that they work in. So we need to partner directly with DHBs, private surgical hospitals, PHOs, etc., and that's exactly what we're doing, and bringing the professional bodies and agencies in here. So our list of stakeholders is enormous, but that's how we believe that we're going to be able to make some influence. So in the 3 and a bit years that we've been running, just want to give you one example. This is from the medication safety area. Have any of you heard of the complications that arise from taking sodium valproate, which is a common anti-epileptic, during pregnancy and the effect on the fetus? Some of you have. We've still got more work to do, obviously. So if it was brought to market by a French company, Sanofi, late 1960s, the French believe that they've probably damaged up to 4,000 babies. We're not sure in New Zealand how many may have been affected. If you're taking a moderate dose, like 1,500 milligrams, the chance of having physical defects will be 1 in 4, but the cognitive defects are also more subtle, and sometimes they don't show up for long. But essentially what the research tells us now is they knock about 10 IQ points off the child. So this is not an inconsequential issue, and in fact most regulators in the world are now suggesting don't use it for anything other than epilepsy, because it's used for mood, also for pain management and migraine, etc. And also try everything else before you resort to sodium valproate. It's okay for us blokes, but no good for the females. So we've gone out to target consumers, prescribers and dispensers, because despite alerts being issued by MedSafe, it did not change prescribing practice. So that's been out there in the real world for 15 months now, and the good news is that the prescribing rates are falling. And the other good news is that we've had a Health Select Committee focus on this, and in actual fact there's now going to be a great deal more emphasis, I believe, on this. So the process of taking some data, which produces a fetal anticonvulsant syndrome, and turning it into something can actually have a constructive impact in New Zealand. I just want to remind you that this isn't a linear process, so obviously the monitoring and evaluation feeds back. And so we're looking at, for example, prescribing rates of sodium valproate by age groups. And interestingly enough, the females who are just getting outside of the childbearing years are the ones where they have picked up on this message faster than the younger women. And that means we need to have a greater target there. Now, rest assured, our main way of getting to those is through social media. So that's part of this feedback loop that we need to take account of. So I'm going to hand over to Zeeman to finish off.
Just before I get into the slide, I think people need to realize the sort of breadth of data sets that ACC actually has access to. Obviously, everybody's aware of the fact that we, treat accidents. We basically look after that. So obviously, we're sort of linked into the healthcare sector. But a large part of what we're focusing in on going forward really has to do with injury prevention. And that means that we have access to information that allows you to do certain things which traditionally would have been very difficult to do and in a lot of cases almost impossible. So we're busy finalizing a paper at the moment on looking at road accidents across New Zealand. This is not just motor vehicles, but anybody who was basically injured on a road in New Zealand. And what happened is that NZTA said, how do we actually look at the data in terms of road accidents in New Zealand? And so they went to the trauma registry people at Waikato and said to them, what have you got in this space? They said, well, we've got a limited amount, but you should actually be talking to the Ministry of Health because they've got a lot more. And so they went off to talk to the Ministry of Health, and the Ministry of Health said to them, you actually need to talk to ACC because they've also got some data in this particular area. And so what happened is a couple of us, about 5 or 6 of us, got together in a room and started having a discussion about where the data sets resided that actually could support the kind of analysis that we were actually talking about. And as it turned out, ACC, because of our involvement in road accidents, actually has access to the crash analysis system, which comes from NZTA but is used by police to record serious accidents on the road. So that's one source of information. We also have a bulk funding arrangement between Ministry of Health and ACC for ambulances within New Zealand, which means we have access to data from an ambulance point of view in terms of who was picked up at an accident site, who was treated on the site, where were they transported to, and actually can track them in terms of what actually happened on their patient journey. Now, not all people are sort of treated by or attended to by ambulances, but essentially, we could at least find those people. Then you have the situation of where did they actually end up. So if you start looking at the data that's available from the Ministry of Health, again, because we have a bulk funding arrangement as far as healthcare is concerned, we have access to the NMDS, you can find information there about who was actually admitted to hospital. The NNPAC database actually gives us information of people who were treated for less than 3 hours at an ED, but obviously were not admitted to the hospital. Then there are the more serious cases which are actually transferred into the trauma registry, so we know who those people are. And ultimately, most of these things end up as claims with ACC. So the claims which are not recorded in some of these systems are things which are actually treated by a GP. Not everybody who has an accident actually goes for treatment. They might just go to their local GP and have something attended to. But essentially that way we could actually track exactly what the treatment pathways were for people. Where would the accidents happen? How were they transported? Were they transported? Did they go home? Did they only see a GP 3 or 4 days later because they realized it was a bit more serious than they actually thought? And can actually track the whole pathway of people who were injured on the road. And that's something that's quite significant. If we didn't have the ability to link all these data sets together, we actually wouldn't be able to track those people through their journey through the system. And I think these are sort of the things that we need to do in the future, sort of how do we get a longitudinal view of patients and their journeys. I think we have very much a snapshot kind of view for some of the events that actually relate to patients, but we actually don't have a holistic view in terms of what actually happens with them on their whole journey. And obviously there's a lifetime journey that you also need to take into account. So I thought just in summary, I think some of you may have heard some of the comments that have already been made in terms of ACC and MIT working together. So we signed an intent this week. And the whole idea is that we start cooperating on certain areas. To be defined, we've initially had some discussions about treatment injury, but we need to start thinking about what are the things we want to work on going forward. Obviously, we then have an information need. We may be able to construct things which we can use in terms of the particular engagement between ACC and MIT. And then hopefully in the future that could form the backbone of trying to create a kind of data set that could be shared across the whole sector and for researchers and people to be able to get access to that information as well. So this is very much the start of the journey. I think we have a long way to go. We have an opportunity to do some really creative things in New Zealand. We have an opportunity in terms of data, which probably few countries in the world actually have. We know we have a number of unique kind of situations as far as data is concerned. This morning there was a discussion about where you can find certain data. Now, one of the things between Ministry of Health and ACC in terms of supplying data, we've actually been talking to the global burden of disease people, and we'll provide them information in terms of accidents, for instance, for New Zealand. And they actually view our data as being the gold standard. We're the only place in the world where we have a situation where you have an organization like ACC, where we know we actually record most of the accidents that in fact happen in New Zealand. In most other countries, those things actually don't happen because there's no real incentive. There's all kinds of other problems associated with being able to record that kind of information. But it gives us an opportunity. The last point is that obviously, as ACC, we can't do things on our own. And so we've invited Ministry of Health to participate in the process, and they were part of the discussions that we had earlier this week in Wellington. Okay, so can I just a quick summary for the last one? So basically the idea was that the treatment injury stuff was sort of a temporary kind of situation where we sort of were trying to create a data set that we could use for a hackathon. And hopefully we will have something like that for next year. And obviously the idea is that this is the start of a much longer journey. And hopefully we will see all of you at next year's event, somewhere in January.
Thank you. So I'd like to thank our three speakers, and I'd like to thank ACC for being the major sponsor and for joining the Critical Care Data, MIT Critical Data. So with that, we'll stop the session and carry on. Thank you.